Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 332 of our pharmacotherapy series, which majors in diabetes mellitus. The first question relates to patient QRP in part 331 of this pharmacotherapy series. If QRP were willing to start insulin, why would it be reasonable to use insulin in combination with other antidiabetic agents? How should it be combined with other agents? Is this combination more effective than insulin alone? Most patients with type 2 diabetes mellitus eventually require insulin. The combined use of insulin with a variety of oral agents has been extensively evaluated, but the studies differ in their interventions. In some studies, single doses of an intermediate or long-acting insulin or once or twice daily doses of premixed insulin are added to a single or combination of oral antidiabetic agents in poorly controlled patients. The primary outcomes that have been evaluated include measures of glycemic control, e.g., A1C, or fasting plasma glucose, and the extent to which insulin doses have been decreased. DeWitt and Hirsch published a comprehensive review of these studies, and readers are referred to this article for this evidence. The combined use of insulin and oral agents can be considered based on the ACCE algorithm, particularly when the A1C is higher than approximately 9%. Before starting insulin, it is important to review the blood glucose profile. 1. Fasting hyperglycemia, which may improve or persist throughout the day. This is the more typical glucose profile for patients with type 2 diabetes mellitus, in whom addition of basal insulin at nighttime would be the most appropriate next step. 2. Fasting blood glucose is a target with daytime hyperglycemia. This is less common for people with type 2 diabetes mellitus, in whom addition of prandial insulin would be an appropriate next step for therapy. In QRP's case, it makes the most sense to add a single dose of basal insulin to metformin and glimepiride, with the potential to discontinue glimepiride once the insulin dose is optimized. Advantages attributed to adding insulin to an oral agent as the next step after failure, as opposed to using insulin alone, include the following. 1. Lower insulin dosages can be used, and this minimizes weight gain and hypoglycemia. 2. Simpler, single-dose insulin regimens are possible, versus monotherapy with insulin. 3. Lowering the fasting glucose concentrations improves glucose control throughout the day because glucose excursions related to meals are layered over lower values. Furthermore, lower glucose values improve beta cell responsiveness to glucose and enhance tissue responsiveness to insulin action. However, lowering glucose concentrations is the first priority, not attempting to use lower insulin doses. QRP should be started on 10 units or 0.2 unit per kilogram of neutral protamine hagedorn, or basal insulin glargine, detamir or degludec. This dose is based on empiric use of insulin in a variety of studies, 0.1 to 0.2 units per kilogram, and a conservative estimate for basal insulin of approximately 0.5 units per hour. QRP weighs 155 pounds, or 70.5 kilograms. The dose also takes into account the possibility that QRP is secreting some basal insulin of her own and will have some residual stimulation of insulin secretion by glipizide. The basal dose should be titrated upward based on the fasting plasma glucose for 3 consecutive days. A common titration method used is the treat-to-target schedule. In QRP's case, it makes the most sense to add a single dose of basal insulin to metformin and glimepiride, with the potential to discontinue glimepiride once the insulin dose is optimized. Advantages attributed to adding insulin to an oral agent as the next step after failure, as opposed to using insulin alone, include the following. 1. Lower insulin dosages can be used, and this minimizes weight gain and hypoglycemia. 2. Simpler, single-dose insulin regimens are possible, versus monotherapy with insulin. 3. Lowering the fasting glucose concentrations improves glucose control throughout the day because glucose excursions related to meals are layered over lower values. Furthermore, lower glucose values improve beta cell responsiveness to glucose and enhance tissue responsiveness to insulin action. However, lowering glucose concentrations is the first priority, not attempting to use lower insulin doses. QRP should be started on 10 units or 0.2 unit per kilogram of neutral protamine hagedorn, or basal insulin glargine, detamir or degludec. This dose is based on empiric use of insulin in a variety of studies, 0.1 to 0.2 units per kilogram, and a conservative estimate for basal insulin of approximately 0.5 units per hour. QRP weighs 155 pounds, or 70.5 kilograms. The dose also takes into account the possibility that QRP is secreting some basal insulin of her own and will have some residual stimulation of insulin secretion by glipizide. The basal dose should be titrated upward based on the fasting plasma glucose for 3 consecutive days. A common titration method used is the treat-to-target schedule. Alternatively, the basal insulin dose can be increased by 2 units every 3 days until the fasting plasma glucose is in a target range, 80 to 130 mg per deciliter. If the fasting plasma glucose is greater than 140 to 180 mg per deciliter, larger increments can be used, e.g., by 4 units every 3 days. If hypoglycemia occurs or the fasting plasma glucose is less than 70 mg per deciliter, the dose should be reduced by at least 4 units, or by 10% if the dose is more than 60 units. Of note, U300 glargine and U100 and U200 degludec should not be titrated sooner than every 3 to 4 days. If there is no improvement in glycemic control after 3 months, prandial insulin or a glucagon-like peptide-1 receptor agonist should be added. At that point, the insulin secretagogue, in QRP's case, glimepiride, is usually discontinued, but metformin should be maintained. An alternative for QRP is to discontinue the sulfonylurea and begin insulin monotherapy using methods similar to those described for type 1 diabetes mellitus patients. This option also is rational based on the observation that patients like QRP are likely to require insulin therapy because of progressive beta cell failure. Furthermore, insulin monotherapy may be less expensive and easier to assess than combination oral agents plus insulin therapy. Nevertheless, many clinicians use single doses of basal insulin in combination with oral agents as a bridge to eventual insulin monotherapy, especially for those patients unwilling to adhere to multiple daily insulin injections. In the setting of insulin resistance, such as with type 2 diabetes mellitus, continuing metformin therapy should be a priority if at all possible. The next question reads, QRP's insulin glargine dose was eventually titrated to 25 units at bedtime. In combination with glimepiride 4 mg per day and metformin 1000 mg twice daily, her fasting glucose levels fell to the 110s and 120s on most occasions. Her A1C dropped to as low as 6.9%. However, after 1 year, she began to note a gradual rise in glucose concentrations throughout the day. This resulted in a further increase in her bedtime insulin glargine to 40 units, that is 0.57 units per kilogram. Currently, her morning blood glucose levels are 120 to 140 mg per deciliter, and blood glucose levels before or after meals range between 170 and 200 mg per deciliter. Her recent A1C value was 8.5%. For the past 6 months or so, QRP has noted increasing fatigue, bouts of blurred vision, and recurrence of hormonal infections. How should she be managed now? The next step in managing QRP's diabetes mellitus is to institute prandial insulin therapy, which is needed as indicated by her daytime hyperglycemia. Like type 1 diabetes mellitus patients, those with long-standing type 2 mellitus disease may require prandial insulin before meals to minimize postprandial excursions. Insulin lispro has been shown to decrease postprandial glucose concentrations to a greater extent than regular insulin, 30% lower at 1 hour and 53% lower at 2 hours, and was associated with a lower rate of hypoglycemia, particularly between midnight and 6 a.m., 36%. However, A1C levels were not significantly different after 6 months. A similar response with insulin aspart and glulisine would be expected. Because QRP is on insulin glargine, the most appropriate next step is to add prandial insulin using a rapid-acting insulin. Initiation of basal bolus insulin regimens are discussed in detail in the type 1 diabetes mellitus insulin therapy section. An easy way to introduce prandial insulin is to initially add only one mealtime dose. The pre-meal blood glucose levels that are associated with the most hyperglycemia are targeted. For example, if the pre-lunch blood glucose levels are elevated, a prandial dose at breakfast is added, or if the bedtime blood glucose levels are mainly elevated, owing to large dinners, a prandial dose at dinner is added. Once a patient adjusts to this, prandial insulin is added to the other meals. At that point, glimepiride dose should be reduced or discontinued altogether. Patients with type 2 diabetes mellitus may require large insulin total daily doses that is greater than 1 unit per kilogram to reach A1C targets less than 7%. Although not technically insulin monotherapy, metformin is often continued to assist in reducing insulin resistance and minimizing weight gain with insulin. The next question reads, QRP has difficulty adhering to a basal bolus insulin regimen. She is currently taking insulin glargine 38 units at nighttime and approximately 7 units of insulin aspart before each meal. She follows a high sugar correction scale. What options are available for QRP? Because people with type 2 diabetes mellitus retain some pancreatic function, it often is possible to achieve an acceptable level of control with twice-daily doses of intermediate-acting insulin in combination with rapid or short-acting insulins, which are available as pre-mixed insulins. These are referred to as split mixed insulin regimens. Although convenient, they do limit flexibility in dosing, and thus A1C lowering ability without increasing hypoglycemia risk. In the United States, fixed mixtures of neutral protamine hagedorn and regular insulin in a 70-30 ratio and a 50-50 ratio are available. Commercial combinations of the rapid-acting insulins plus an intermediate-acting insulin also are available as Humalog Mix 75/25, a mixture of insulin Lispro plus Lispro protamine suspension, Humalog Mix 50/50, a mixture of insulin Lispro plus Lispro protamine suspension, and Novo Log Mix 70/30, a mixture of insulin aspart plus aspart protamine suspension. These fixed mixtures are available in pre-filled syringes, which can add to their flexibility and convenience for administration. The treating to target in type 2 diabetes, abbreviated as 4T, study assessed the efficacy of a basal insulin, detamir, prandial insulin, insulin aspart, and biphasic insulin, Novo Log Mix 70/30 regimen added to patients on metformin and asulfonylurea. After 3 years, a biphasic-based insulin regimen was found to be less effective in achieving an A1C goal of less than 6.5% compared with prandial and basal insulin regimens, 31.9%, 44.7%, and 43.2%, respectively. Despite the findings of this large multi-center study, use of twice-daily, pre-mixed insulin remains a common insulin therapy for patients with type 2 diabetes. QRP is currently receiving a total daily dose of insulin of 59 units, or 0.84 units per kilogram per day. To convert her to a pre-mixed insulin, one could begin with a conservative total daily dose of 0.5 to 0.6 units per kilogram per day, split equally before breakfast and dinner. An older method of 2/3 in the morning and 1/3 in the evening is used less commonly now. When starting an insulin-naive type 2 diabetes mellitus patient on pre-mixed insulin, doses of 5 to 6 units twice daily, administered before breakfast and dinner, are often used, with the doses being titrated before breakfast to affect pre-lunch and pre-dinner glucose levels, and before dinner to affect the bedtime and fasting glucose levels. If the premixed insulin does not achieve adequate glycemic control, an option is to mix the short or rapid-acting insulin with neutral protamine hagedorn in the same syringe. By doing this, each insulin dose can be individually adjusted. A disadvantage to this is the chance for patients to make errors in measuring and mixing insulin, especially in the elderly when they may have vision and/or dexterity issues. Alternatively, a prandial dose of rapid-acting insulin, i.e., a third injection, can be added at lunch. The breakfast dose of pre-mixed insulin should be decreased as well. Another option is to add a third dose of the pre-mixed insulin at lunch, so pre-mix insulin thrice daily. However, the lunchtime dose is smaller than the breakfast and dinner dose. An initial pre-mixed insulin lunchtime dose of 2 to 6 units, or 10% of the current total daily dose of pre-mixed insulin, can be started. QRP should be started on a rapid-acting pre-mixed insulin twice daily, as this has the convenience of being administered right before eating, within 15 minutes. A dose of 20 units subcutaneously twice daily represents a conservative starting dose. She should monitor her fasting and pre-dinner blood glucose levels, at a minimum, to further adjust her insulin doses. The next question reads, MAP, a 62-year-old woman, has had type 2 diabetes mellitus for 11 years. She is currently taking metformin 500 mg orally thrice daily and insulin glargine 47 units at bedtime. Her A1C is 8.2%. She tries to follow a meal plan that a dietitian developed for her, but her BMI remains 31 kg per meter squared. Her physical activity is limited because of an arthritic knee, for which she plans to have knee replacement surgery in the future. Other medical problems include hypertension managed with hydrochlorothiazide 25 mg daily and benazepril 40 mg daily, and dyslipidemia managed with atorvastatin 40 mg daily, which are both well controlled. Can any antidiabetic agents be added to her current therapy? The thiazolidinedians have been well studied in patients with type 2 diabetes mellitus who are already taking insulin. In a meta-analysis, pioglitazone lowered A1C by 0.58% when added to insulin therapy. Unfortunately, it was associated with weight gain of 3 kg and increased peripheral edema and therefore should be avoided. A glucagon-like peptide-1 receptor agonist would be a logical agent to considering adding in obese patients. Any glucagon-like peptide-1 receptor agonist would be a good option. The agents should be chosen based on cost, effectiveness, and adherence. For example, exenatide may be the only glucagon-like peptide-1 receptor agonist on formulary, or perhaps MAP has trouble remembering to take once-weekly medications, such as dulaglutide, and as such would be more successful with once-daily liraglutide. Adding a dipeptidyl peptidase 4 inhibitor would be another option. Sitagliptin is FDA approved for use with insulin, however, the A1C lowering may be less than with a glucagon-like peptide-1 receptor agonist. Therefore, addition of liraglutide may be a reasonable approach in MAP. Her A1C can reach her target goal of less than 7%, with potential for weight loss and lower insulin glucagon requirements. Liraglutide should be initiated at a dose of 0.6 mg injected subcutaneously once daily for 1 week, after which the dose should be increased to 1.2 mg once daily. Some patients may require further titration to a maximum dose of 1.8 mg once daily to reach the glycemic targets. The next question reads, MCA is a 73-year-old woman who has had a 20-year history of type 2 diabetes mellitus and a 5-year history of mild renal dysfunction, with a serum creatinine of 1.2 mg per deciliter, an eGFR of 47 ml per minute per 1.73 meters squared, and a BUN of 22 mg per deciliter. Her son, who lives with her, quickly called 911 when he noticed his mother appearing lethargic and sleepy, with her eyes closed, as she was sitting on the couch. He assumed she was having a low sugar reaction. When the paramedics arrived, her blood glucose concentration was 46 mg per deciliter. MCA was able to be aroused, and indicated she could drink something, so 4 ounces of orange juice was administered. After 10 minutes, her blood glucose level was 80 mg per deciliter, so she was given another 4 ounces of juice. According to her son, MCA's diabetes has been well controlled for the past several months with glyburide 10 mg twice daily and metformin 850 mg thrice daily. For the past 3 days, MCA has been eating less and vomiting on association with the flu. What was the likely cause of her hypoglycemic episode? Were there any predisposing factors? MCA has experienced a hypoglycemic episode secondary to glyburide. Hypoglycemia is the most common and potentially severe adverse effect of the sulfonylureas. The incidence and severity of this effect increase with the duration of action and potency of the agents. Most sulfonylurea-induced hypoglycemia occurs in patients who are predisposed to hypoglycemia in some way, and MCA is no exception. She is an elderly woman with renal impairment who was on relatively high doses of an agent, a portion of which is excreted unchanged in the urine. Even in the face of decreased carbohydrate intake, due to reduced appetite and vomiting, she continued to take her usual dose of glyburide. Even though the stress of illness most often raises glucose levels, the decreased food intake resulted in glyburide causing hypoglycemia. Because glyburide has a long duration of action, hypoglycemia may last for several hours. MCA and her son should be educated about treatment of hypoglycemia. It is likely that her son did not need to call 911, and he could have treated the hypoglycemia. Glucagon should not be used to treat hypoglycemia caused by a sulfonylurea, as glucagon can cause a paradoxical fall in the glucose levels. The next question reads, MCA has mild renal insufficiency, that is an eGFR of 47 ml per minute per 1.73 meters squared, and is taking the maximal dose of metformin. What is the risk of lactic acidosis with metformin? How should age and kidney function be taken into account with metformin use? Which agents should be avoided? Which agents could be used? Sulfonylurea compounds that are metabolized to active products that depend on the kidney for elimination, e.g., acetohexamide, chlorpropamide glyburide, and tolazamide, should be avoided in the elderly and in patients with decreased renal function. Sulfonylureas that are completely metabolized to inactive or weakly active products may be used, i.e., glipizide, glimepiride, or tolbutamide. Although glyburide is unlikely to accumulate in patients with a creatinine clearance greater than 30 ml per minute, it should not be used in MCA because it caused a severe hypoglycemic reaction. MCA should be instructed to eat regularly because skipped meals may result in recurrent hypoglycemia. Consideration to discontinuing the sulfonylurea and adding an agent with a lower incidence of hypoglycemia should be considered. The most notorious side effect associated with metformin, although extremely rare, is lactic acidosis. The risk of lactic acidosis is increased with renal insufficiency, which can result in accumulation of metformin because it is almost exclusively cleared unchanged by the kidneys. Lactic acidosis is a metabolic acidosis characterized by a significant reduction in the arterial pH and an accumulation of serum lactate, a product of anaerobic metabolism. It is a condition that is highly lethal, that is 50% mortality, and resistant to therapy. Lactic acidosis occurs when there is an increased production of or decreased utilization of lactate. Decreased utilization of lactate occurs when tissues are unable to oxidize lactate to pyruvate. These two substances are normally present in the serum in a ratio of 10:1. Metformin might predispose a patient to lactic acidosis by augmenting anaerobic metabolism or by decreasing the kidney's ability to handle an acid load. Other factors that might contribute to lactic acidosis include severe cardiac or pulmonary disease, anoxia, increased lactate production, septic shock, renal dysfunction, retention of metformin and lactate, patients receiving contrast dye, and excessive alcohol intake, increased lactate production and decreased utilization. Signs and symptoms generally are acute in onset and commonly include nausea, vomiting, diarrhea, and hyperventilation. Hypovolemia, hypotension, confusion, and coma also may occur. Death is usually secondary to cardiovascular collapse. Typical laboratory findings include a low serum bicarbonate and CO2, a low arterial pH, an elevated potassium, a normal or low serum chloride, elevated lactate and pyruvate levels, an increased lactate to pyruvate ratio, and an anion gap of 30 milliequivalents per liter or higher. Although metformin rarely is associated with lactic acidosis, the manufacturer and the FDA have taken extreme measures to prevent its improper use because another biguanide, fenformin, which induced this life-threatening condition, was removed from the market in 1977. The estimated rate of metformin-induced lactic acidosis was 0.25 to 4 cases per 1,000 users versus 5 to 9 cases per 100,000 users for metformin. A group of clinicians from the FDA summarized 47 confirmed cases of metformin-related lactic acidosis, that is lactate levels equal to or above 5 millimoles per liter, that had been reported to the FDA between May 1995 and June 1996. Unfortunately, the condition continues to be resistant to treatment. The mortality rate was 43%. Importantly, 43 of the 47 cases, 91%, had concurrent conditions that predisposed them to lactic acidosis. These included cardiac disease 64%, decreased renal function 28%, and chronic pulmonary disease 6%. Several patients, 17%, were older than 80 years of age and may have had decreased renal function despite normal serum creatinine concentrations. Interestingly, 38% of the patients had heart failure, and those who died were more likely to be under treatment with digoxin and furosemide. The mean daily dose of metformin was well within the therapeutic range and was not higher in the group that succumbed, 1,259 plus or minus 648 mg in the group that died, and 1,349 plus or minus 598 mg in the group that survived. Metformin should be initiated with care in patients older than 80 years of age because of the potential for a low GFR, even when serum creatinine is normal. Because MCA has moderate renal dysfunction, GFR 40 ml per minute, lower the dose of metformin to 500 mg twice daily to minimize the potential for accumulation. The thiazolidinediones are primarily metabolized by the liver and are not contraindicated in patients with mild renal failure. The use of pioglitazone, beginning with low doses, could be considered, as can acarbose, which is poorly absorbed from the GI tract. The dipeptidyl peptidase 4 inhibitors could also be used, but the doses may require adjustment depending on the degree of renal dysfunction, except for linagliptin. Exenatide can be used in patients with creatinine clearance greater than 30 ml per minute, and the dose does not need to be adjusted. Liraglutide should be used with caution in renal insufficiency, but does not require dose adjustment. None of these agents cause hypoglycemia when used as monotherapy. The next question reads, BRY, a 60-year-old man with cirrhosis of the liver, is found to have type 2 diabetes mellitus. Glipizide 10 mg per day is initiated. How will BRY's liver function affect the disposition of glipizide and his response to this agent? Most non-insulin antidiabetic agents should be avoided in patients with severe liver disease, and insulin therapy is often the safest option. Because hepatic metabolism is the primary route of elimination for most sulfonylureas, including glipizide, patients with hepatic disease should be expected to have an exaggerated response to those drugs metabolized to less active products. Liver disease can be a separate predisposing factor for severe, prolonged hypoglycemia because glycogenolysis and gluconeogenesis are impaired. Thus, sulfonylureas are relatively contraindicated for cirrhotic patients. If they are used, shorter-acting agents are preferred, and small initial doses should be used. For BRY, glipizide could be initiated at a dose no greater than 2.5 mg per day and increased if needed by 2.5 mg increments at no less than weekly intervals. Other options are low doses of repaglinide, dosed at 0.5 mg, or nuteglinide, dosed at 60 mg with meals because they are very short-acting. Other good options for which severe liver disease is not a specific contraindication include glucagon-like peptide-1 receptor agonists, dipeptidyl peptidase 4 inhibitors, and sodium glucose cotransporter 2 inhibitors, although there is little data regarding their use in these patients. Basal bolus or mixed insulin regimens are also good choices. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 333.